Okay, good morning everywhere but on the East Coast, and good afternoon for those of us who are on Eastern time. My name is Carolyn Holland. I'm an associate professor of emergency medicine at the University of Florida, Gainesville, and I'm the moderator for today's sessions, oral abstracts for patient safety and quality, as well as disease and injury prevention. The format for today is that we will have 10 minutes for our speakers, and then a 2-minute question and answer period. As the moderator, I'm going to try to keep us on time. And are there any questions before we get going? You're welcome to put your questions in the chat box, which I'll be monitoring, or when the question and answer period starts, you can actually unmute yourself and speak out loud. I think all of us have Zoomed enough this year that we know how to do that. So without further ado, I'd like to introduce Dr. Daniel Satnick. He is faculty at Mount Sinai, and we'll be talking about the development and validation of a quality improvement tool for documentation and clinical care. Take it away, Dr. Satnick.
Hello, let me just share my screen and we'll get started. Okay. And I'd like to point out I have some other members of the simulation division with me, most notably Dr. Heidi Baer is here, and this was kind of her brainchild along with Dr. Eric Legome. Let me start the slideshow. Okay. Can everyone see the slideshow?
Looks perfect.
Okay, excellent. All right, so we're going to go ahead and get started. So as mentioned today, I'm going to be discussing the development of a quality improvement tool for peer evaluation of documentation and clinical care in the emergency department. Next slide. Okay.
You're advancing.
This is a talk about documentation, clinical care, and how we can do better. If we take away all the annoyances, the billers, the crashes, the sepsis alerts, the heart of documentation is to communicate a patient, a presentation, evaluation, and treatment. We need to synthesize everything that's happening into this note, and we need it to make sense. When my colleagues read my chart, I want them to look like the woman on the left, not the man on the right. Now, you might be asking yourself, why are we talking about this? I did residency, I've been practicing independently for a while. Well, then you might also realize that documentation is not strictly a focus during or after training. The percent of cases with charting errors in emergency medicine is unknown, and it's likely a function of how it's defined. But a single center study found charting errors by trainees in a teaching hospital to be between 14 to 24% of charts, depending on their time in training. The 14% was after the intervention. While emergency medicine residents feel they require more training and documentation, this is not well studied in attendings. In addition, most departmental training for emergency medicine attendings usually focuses on billing rather than medical, legal, and charting and clinical charting. It's hard to make a direct connection between money and better documentation, but it does exist. Poor documentation, discrepancies between the attending, resident, PA, and nursing notes, missing medical decision-making, missing progress notes, as well as inappropriate care, play a major role in claims and payouts of emergency department medical malpractice cases. So even though we may feel like this person pictured when we try to sit down to write a note on shift, the lawyers won't have any of those distractions when looking through your chart. Okay, you guys know this. This is all background. It can feel helpless sometimes. So how do we get better? Like most other skills, it starts with evaluation. Here's another number. That's how many charts each attending at our site had reviewed on an annual basis. 2 charts bi-yearly as part of ongoing professional assessment by our department chair, Dr. Eric Legome. 1 person and 4 charts in a year is hardly enough for significant feedback. We realized that a strategy to regularly alert our attendings of suboptimal documentation and patient care was needed to improve care and avoid costly errors in the future. In addition, understanding common minor and uncommon major deviations in charting or care may allow emergency department leadership to provide targeted intervention to prevent them from causing major adverse events. In discussion with other department chairs, Dr. Legome discovered there was already a tool created for a similar purpose. This slide highlights a scoring tool used by Klasko et al. To assess the rates of error and adverse events in the emergency department. Shown here are the types of errors identified using their tool. We modified this previously developed template that demonstrate high inter-rater reliability for a more streamlined, simpler, and generalized scoring tool. For our scoring tool, we chose to focus on documentation and clinical care. Our thought process was these were most easily determined from chart review, and they incorporate aspects of the other criteria listed above. Here you can see the scoring tools. Don't worry, the next couple slides are going to focus on them in a little more detail, but you can see the documentation scoring sheet and you can see the clinical care scoring sheet. I want to highlight that it's a Likert scale, 1 through 5, 1 being the best, 5 being the worst. Let's take a look at scores of 1, 3, and 5 for each of the documentation and clinical care scoring sheets. Here you can see a score of 1 for a chart with documentation. Just take a look at the top part. It says charting is complete for all major elements, and there are some examples of what that might mean. For 3, you could see it means that the chart is inadequate for the complaint, and you could see a few examples of what the scores were looking for there if they chose a 3. And at 5, does not need much of an explanation. It's a marked deviation from the standard or minimal expected documentation. As for clinical care, you could see a 1 is fully appropriate for the presenting complaint. A 3 means that most attendings would have managed the case differently. And a 5 is defined as indefensible for a poor outcome. We also provided examples for each of the documentation and clinical care. These are examples of what sort of case documentation would fit into those Likert scores. So once we had our scoring tool developed, we had 8 experienced attending physicians evaluate the same 10 charts using our scoring rubrics. These charts were specifically selected by our department chair, who was not in this review, to provide a mix of what he considered excellent, adequate, and poor documentation and clinical care. Our attendings then took these charts and they reviewed them using the scoring tool, and we looked at the consistency among raters using the Shrout-Fleece relative fixed set mean kappa scores. As you can see here, the kappa score showed excellent consistency among the raters for both documentation and clinical care. And as such, we concluded that a modified, simplified QI scoring rubric demonstrated consistency among experienced attending physicians, and we went ahead and used it as a standardized tool for departmental review. So we expanded the tool to include all of our attending providers, a group of 58 attendings, and they were each assigned 12 charts, 12 different charts for review. There were over 600 charts reviewed, and at the end, blinded, consolidated, and individualized feedback was provided to each attending. Overall, we found that 90 to 95% of the charts met level 1 or 2 criteria. In the ones that did not meet this criteria, certain themes emerged. As you can see above, these themes were lack of evaluation or notation of competency on AMA departures, inconsistencies between resident and attending charting, and lack of reassessment notes. One last slide. Okay, so we believe that by requiring all attending staff to review a specified number of charts using a template with explicit criteria, it'll give them a better understanding of elements of a good chart as well as opportunities for improved care and resource utilization. They'll be able to understand the risks involved with missing critical elements of charting, as well as learn by reviewing other attending charts. This process is easily generalizable and scalable to any emergency department, and we're currently looking to expand the review to include residents and mid-levels at our site, as well as the rest of the emergency departments within our Sinai system. Thank you, and I'm going to stop screen sharing and take any questions at this time.
Okay, at this point, this paper is open for questions. I'm going to start if that's okay.
Sure.
When you had the large selection of charts that the general faculty all looked at, how were those charts selected? Were they?
Okay. Yeah, good question. That was an EPIC data pull. So we got an assist from one of our quality improvement specialists, and she did a big pull of EPIC charts in a specified time frame. And we pulled 12 charts from each provider. So they were completely random.
Okay, so not any electronic triggers like we're going to look at this on patients who return admitted or, died in the department or return within 48 hours or anything like that.
No, originally, and Dr. Bear can jump in if she wants. So originally we were going to maybe focus on the 72-hour return, but we decided to keep it more broad for the first iteration of the study.
Awesome. Yeah, Dr. Bear said random in her comment in the chat section. Any other questions for Dr. Satnick? I will tell you, as the person who does the QA for my department, we look at a number of charts based on triggers every month, and I like that this had a good kappa, and I might actually trial this with my faculty because we have faculty review charts every month. So perhaps you and I can chit chat and we can see about some sort of collaboration, because I find it fascinating because it's interesting when I have people reviewing charts, I give them a set of questions to think about, but this is much more structured. And sometimes I don't think that people actually read the charts when I ask them to review them. I mean, I still review them all also, but okay. Any last call for questions for Dr. Satnick? You got a shout out from Yaz.
Yeah, nothing would make us happier. I see Dr. Bear looks very satisfied. That was the goal of the project, to simplify chart review and kind of make it more democratic.
Yep. Okay, so thank you so much for the wonderful presentation. We're going to move on now to Dr. William Ryan from the University of Central Florida. And he's going to be speaking on the etiology of medication errors discovered by a pharmacist-based medication reconciliation program. So you can go ahead and share your screen, sir.
I'll do that. Share. There we go. All right, so hi, my name is William Ryan. I'm a rising third-year medical student at the University of Central Florida College of Medicine. And this is our presentation on the etiology of medication reconciliation errors discovered by a pharmacist-based medication reconciliation program. This is just our slide of financial disclosures, as we have none. So some background. So complete and accurate medication reconciliation is an important component of the for the prevention of medication errors. And there have been many hospitals, especially emergency departments, that have been utilizing pharmacists to conduct medication reconciliation in order to limit the amount of errors of inappropriate medication administration. And although this has been done throughout many hospitals, there's been little research to assess the progress of this process. So the objective of our study was to evaluate the types of medication errors that have been discovered by and corrected by pharmacists in the emergency department at the time of admission. So this is how we did the we performed the analysis. The hospital that we did this at was a 318-bed suburban hospital, and at this hospital, pharmacists performed medication reconciliations at the time of admission or observation status. And this is a process that had been going on for 2 years at the time when we decided to do this study. So we had taken a 1-month subset of this data in order to analyze it. And the data that they collected included the age, number of patient medications, number of discrepancies, and the types of reconciliation discrepancies. And the data was analyzed to assess the number of medication changes as well as the category of errors associated with it. And we had 2 different types of errors that we considered. We considered we had major errors and minor errors, or just major errors and just regular errors. And we considered major errors to be those that included missing medications or inaccurate medications, as in one medication was put down instead of another one. So during the study, we had approximately 618 patients enrolled, and the mean age was about 66.6 years. The mean number of medications per patient was about 9.2 after the pharmacist reviewed it, and the mean amount of time that it took for medication reconciliation was 25.4 minutes with a range of 0 to 115 minutes. And we found that there was actually a decent number of medication errors per patient, approximately 6.9, And 4.1% of these errors were considered major errors, which were the ones that include the inappropriate medication labeled or missing medication. And we assessed, we collected we categorized the types of errors into 8 types, but we found that 5 of these types accounted for about 95% of discrepancies. And this included omitted medications, wrong dosages, wrong frequencies, and medication completed, meaning that the person had, that the medication that was listed was a therapy that they had already completed. And this is just a figure showing the data that I previously mentioned. As you can see, the two types of errors that we found were the highest for the omitted medications and the wrong medications, which is what we labeled as the major errors. So as you can see from this figure, the major errors actually constitute the majority of medication errors that we found. And in this figure, what we did was we stratified the patients by age group. The first age group was 0 to 49 age. And then after that, we did it by decade, going from 50, 59, 60, 69, 70, 79, 80, 89, and greater than 90 years old. And as you can see from this data, the number of medications increased as the age went up, as did the number of errors and major errors. However, after we got past the 70 to 79 age range, the two highest age groups that we collected, the number of errors and the number of major errors actually went down. And what we think that this is due to is that many of these patients in these age groups came from skilled nursing facilities, and they often came in with medication administration records. So we believe that this may be the reason why the number of errors and major errors decreased in these groups compared to the 70 to 79 age range. So some of the limitations of the study were that it was conducted at a single institution, and the fact that many of these patients came from skilled nursing facilities where they had medication administration records with them. And this may have impacted some of the data in some of the groups in the upper age range. In conclusion, pharmacist-based medication reconciliation performed in the emergency department at the time of admission identifies approximately 6.9 medication errors per patient. And wrong medication or omitted medication, which we consider the major errors, accounted for about 4.1 errors per patient, which is approximately about 59%. And despite the effectiveness of this program, it is quite time-consuming. The study found that it took approximately 25.4 minutes for this process to be completed, which means that setting apart a specific subset of the healthcare professionals in order to complete this process could help to alleviate some of the burden on other medical professionals. Great. Does anyone have any questions?
Wonderful. At this point, the abstract's open for questions. I'm going to start with, so I looked, doing the math, you said that there were 618 patients admitted over a month, so that's about 20 patients per day average. How many pharmacists did you have, and were they available 24 hours a day or just 12 hours a day or 8 hours a day?
That's a great question. So I actually am not completely sure about how many pharmacists were on staff. I can contact my team about it, but I'm not sure about that number at the moment. But we did have the pharmacists on for about 12-hour shifts from 11 a.m. to 11 p.m.
Okay. Because I agree, looking at, almost 30 minutes a patient on average, in some place like where I work, where we admit about 50 patients a day, and then another 20 pediatric patients a day, that would be more than 24 hours in the day that it would take to get it done, like 34. So figuring out who's going to do this and making it the most cost-effective person, I think, is going to be key. Anyone else have any questions for, I'll say Mr. Ryan, because you're not quite doctor yet, correct?
Not yet, working on it.
Nope, no more questions? Going once? Going twice? I have to say, I think that this is a really important topic. I know medication reconciliation is hot topic, and making that the job of the bedside nurse or the resident or the admitting resident or the pharmacist everybody wants to, like, not me, because it is so time consuming, but it is critical. So work like this is going to show how critical it is and reinforce the need to have a structured, regular process. So thank you so much.
Thank you.
Okay, we're going to move on. We are cruising along. We're a little bit early. Next up is Dr. Neugebauer. Did I get that right?
Neugebauer, yeah.
Neugebauer, close, I'm sorry.
No, that's perfectly fine.
From Texas A&M, who's going to be talking about return visits within 30 days following evaluation of hyperglycemia in the emergency department. Please feel free to start when you're ready.
Okay, I'm going to go ahead and share my screen here.
There's not the timing of walking up to the podium to make the transition slower. Like
no. All right, we can see everything well, correct?
Yes.
All right, so welcome everybody. I'm Amber Neugebauer. I'm one of the third-year emergency medicine residents at the Texas A&M program in Corpus Christi, Texas. My study is titled The Return Visits Within 30 Days Following an Evaluation for Hyperglycemia in the Emergency Department. First, I'd like to thank my co-authors, Drs. Shu, Ponder, Herrick, Torres, and Richmond. I have no disclosures, financial or non-financial. By way of introduction, so the National Diabetes Statistics Report in 2020 reported that there's roughly 34.2 million people in the United States with diabetes. This is roughly 10.5% of the United States population. In 2015, diabetes became the 7th leading cause of death in the United States. It is the most prevalent chronic disease among all ED patients, and diabetic patients have roughly twice the number of ED visits as non-diabetics. Rates for diabetes continue to rise the most in urban areas of the United States. There's a disproportionate disease burden suffered by minorities and low-income populations. Patients of lower socioeconomic classes and no established primary care provider have been found to have higher ED utilization rates. Insulin dependence may also indicate poorly controlled blood sugars, and these patients may also be more likely to seek care. Of all patients seen in the emergency department for all complaints, roughly 2% of these patients will have return ED visits related to their initial complaint. 85.1% of patients will return due to a persistence of their illness or symptoms. 12% will be found to have a wrong initial diagnosis, and this study found that 2.9% returned due to an adverse event related to their initial treatment. The emergency department has overcrowding and lengthy ED wait times that are seen in many hospital systems in the United States. Recurrent ED visits for several chronic medical conditions have been researched. Many patients with recurrent ED visits have limited access to care. The objective of our study was to determine and identify risk factors associated with repeat emergency department visits within 30 days after an index hyperglycemic encounter in patients with diabetes. By way of methods, our study design was a retrospective multi-center cohort study. The study group were patients that were identified with an ICD-9 or an ICD-10 diagnosis of hyperglycemia, DKA, or HHS over a 5-year period of time. And the study setting was an academic emergency department in an urban setting, and then 4 also system-related community-based emergency departments. The study protocol was index visits and subsequent hyperglycemic ED visits within 30 days were identified in the EMR. Data points from the patient's initial visit demographics were analyzed, and a second blinded author reviewed a sample of records to assess for interrelator reliability. The primary outcome of our study was to identify patient characteristics associated with these recurrent ED visits. In terms of methods, categorical data were analyzed by chi-squared, continuous data were analyzed by the t-tests, and multivariate logistic regression was included in index visits, and patient characteristics was performed to control for confounding, and the odds ratio was calculated. Our results found that there were 327 patients included in our study. The mean age was 53 plus or minus 14 years. 69% of our patients' population was female, 81% of the patients studied were Hispanic. 78% of patients had a primary care provider. 40% of patients had private insurance coverage. 33% of patients used subcutaneous insulin. 20% of patients utilized a combination therapy of oral and insulin therapy. And 52% of patients had an index visit that had a blood sugar greater than 360 milligrams per deciliter. The evaluation of the cause of hyperglycemia as determined by the providing physician in 29% of the cases was noncompliance, and in 56% of the cases was underdosing. The population with recurrent ED visits within 30 days was roughly 30% of our total study group, and 17% of these patients were discharged home after their subsequent ED visit. Bivariate analysis, the following variables were associated with return visits within 30 days. This included medication type, medication noncompliance, and discharged on initial index visit. And multivariate logistic regression found the following were associated with increased risk of 30-day return visits. This was female gender and combination oral and insulin therapy. Inter-rater reliability was nearly perfect for all data points, a few of which included medication type, medication noncompliance, ED disposition, return for hyperglycemia, 30-day outcomes, and number of return visits. In terms of discussion, there's a significant disease burden in which 34.2 million people in the United States have diabetes, 10.5% of the United States population. There's high rates of ED utilization in these patients, and there is a relative lack of research in this realm to determine what causes these repeat ED visits. There was a similar study that was performed by Jan et al., in which they did evaluate the risk factors for recurrent ED visits in patients with hyperglycemia, in patients with diabetes. This was a one-year review of patients. It was a retrospective, multi-center cohort study, and it evaluated within 30 days. So there's a different methodology and a difference in patient population demographics in our two studies. Their study was a Canadian study. There's roughly 3.0 million Canadians, or 8.1% of the population living with diabetes. This study also utilized the generalized estimating equation to account for patients with multiple visits, and they evaluated the risk factors that were identified in each subsequent visit rather than just the initial visit, in which our study evaluated the index visit. Also, it's important, 81% of our patient population was Hispanic. Oh, sorry, there we go. Jan et al., they identified 5 risk factors that were associated with recurrent visits in 30 days. These included a previous hyperglycemic visit within the last month, age less than 25 years, a glucose greater than 20, or for us in the United States, that's 360, being on insulin, and having a family physician. By way of discussion, female gender was identified as one of our risk factors for recurrent ED visits. This has been identified in other studies as being related to increased ED visits or hospitalization. Rowe identified female gender as one of 3 risk factors associated with recurrent readmissions in asthma patients. And Sykes et al. Identified female gender as one of 5 risk factors for increased admission rates into the critical care unit for DKA within 1 year. Another thing that we found was the combination oral and insulin as a risk factor. Patients utilizing insulin had higher rates of ED recidivism in the initial Canadian study. The use of insulin tends to be delayed while other treatment options are utilized initially. Patients on insulin are less likely to be well controlled, and they're more likely to have progressive disease in which there are irreversible disease complications. Insulin dependence may indicate more poorly controlled blood sugars. Limitations of our study: there was the reliance on correct ICD-9 and ICD-10 coding of diagnosis. There may have been patients that were missed if their diagnosis was not coded in their visit. Patient's index visit was utilized to identify risk factors, and they were not evaluated based on the recurrent visits. And each subsequent visit was not evaluated for these related risk factors. Socioeconomic and level of education could have been very important in our study, but these were not reliably documented in each patient's chart. Therefore, we were unable to evaluate for this and comment on that any further. In conclusion, our cohort Diabetic patients with an index presentation of hyperglycemia were more likely to return to the emergency department if they were female or if they utilized combination oral and insulin maintenance therapy. Thank you. I'll open it up for questions now.
Wonderful. Thank you for that great presentation. I'm going to ask the first question, if that's okay. You mentioned that socioeconomic and certainly health literacy probably would have an impact. Did you take a look at all at the payers for these patients and whether, because that can be a marker for socioeconomic status, certainly if they're on Medicare or Medicaid as compared to a private payer or self-pay?
Yeah, so we actually found that 40% of our patient population had private insurance, which was significantly higher than we expected. But we did not have in the charts any documentation of any education background, any socioeconomic background that they had. So like you said, other than pulling our data from that information, we were unable to find anything in their charts that were documented as far as those important backgrounds that we found to lead to higher ED utilization.
Got it. The next question I have is, what do we take away from this? Like, what do you think is the next step now that we've theoretically identified that women and patients who are on both orals and injectable insulin are at risk for coming back? How do we mitigate that, you think?
Absolutely. So I think identifying risk factors is a huge way that we can basically identify the people that we need to be focusing on, whether it be giving them stricter return precautions, identifying reasons now in further studies that led to them coming back, what is in that female population. It can be an additional subsequent study, but just being aware and cognizant that patients that are using those combination oral and insulin therapies might have less well-controlled blood sugars. To identify those patients and maybe give them a little more education and hopefully prevent them from coming back to the ED over and over again.
Awesome. Are there any other questions for this abstract? Super exciting work. Thank you so much. And I'm going to definitely pay attention to those women and people who are on both drugs. So
excellent. Thank you. I appreciate it.
You're welcome. Okay, I believe we're still running a little bit ahead, only 4 minutes, which that's way better than being behind, so that's good. The next abstract is going to be presented by Dr. Kari Samspel. Hopefully I got that correct. And she's going to be speaking on COVID-19 and violence, rising risks and decreased care seeking for sexual assault / domestic violence survivors. And she's from the University of Ottawa. Thank you so much for joining us today, and please feel free to start whenever you're ready.
Fantastic. Thank you for having me. And you did say my name right. Thank you. So I have no conflicts to declare once again, like everyone else here. And I am the medical director for our sexual assault and partner abuse care program within the city of Ottawa, which covers a catchment area of approximately 1.8 million people. And as we all know, the COVID-19 pandemic has hit everybody very hard. Intimate partner and sexual assault violence patients are no different within this category. We know that only 1 in 10 people will disclose having sexual assault or sexual violence within their lifetime to a healthcare provider, but 1 in 3 will have this be an issue for them in their lifetime. So this is something that's more common than a lot of other medical entities that we do take care of over time. Okay, for some reason, there we go. What do we know about this? These patients come to the emergency department. There is a far more vast numbers of people visiting the ED post-violence than visiting any other type of practitioner, probably because we're open all the time and we are the trauma centers for most places. So people can come to us and get help. And that there's significant healthcare costs that are associated with caring for these patients in the emergency department sphere. So, as we all remember from last March, the World Health Organization declared a global pandemic, and the UN shortly afterward issued a warning about risks of domestic violence due to loss of autonomy for individuals. And the stressors put on the world by the pandemic are something that are known to be increased stressors and worries for domestic violence risk factors. So we went to look to see what happened to patients when they were in lockdown. They couldn't leave their homes under a very stressful environment where their livelihoods are under stress. Perhaps there's more substance use to help cope with the stressors of the pandemic. What would happen there? So there was no actual empiric data that actually looked to see what happened during the first wave of the pandemic on survivors of violence. So this was our question, was what was the change in emergency department admissions, which is through which how people get to our program for sexual assault and domestic violence during wave 1. And I will say that we are looking at this during wave 2 and wave 3, but it's slightly messier because those don't have quite the same defined time points as wave 1 had. So our program looked at this in an observational study type way from March 4th to May 5th, 2020, which encompassed wave 1. And we compared it back to 2018 just to have a completely non-pandemic, non-run-up time frame for a direct comparison. And our primary variable was to look at sexual or physical assault during that time frame. As you can see here, the 2018 column is on the left-hand side of your screen. The 2020 pandemic column is on the right-hand side. There were relatively small sample sizes within this timeframe because it was only a 2-month period. We found that we did see fewer patients that were younger at that time frame, so an under 24-year, as the World Health Organization adolescent time frame definition of violence survivors coming to our program at that time. And you can see that there was way less police involvement for patients during the pandemic timeframe as well. We noted overall that we had a 67% reduction in patients seeking care through our emergency department system for sexual assault and domestic violence during wave 1 of the pandemic. And when we normed that against other ED visits, because our overall ED volumes dropped as well, and when we normed it against things like chest pain, which was not a COVID symptom, but also not something that would necessarily be associated with violence, that we had a disproportionate decrease in the patients seen for violence at that time. So you can see that here, that the ED admissions dropped by 32%, whereas we were dropping by about 55 to 60% for sexual assault and domestic violence. Sexual assault dropped in half. Intimate partner violence dropped by close to a half. And having somebody be assaulted by an unknown assailant dropped significantly as well, probably because people are at home with people that they knew. So this is not necessarily a surprising finding that we saw more known patient assailants being seen within our programs. When we looked at health and justice service provision, things that were interesting for us is that for people who were eligible for a sexual assault evidence kit, or otherwise known as a rape kit, those dropped significantly for people wanting to complete this. And if people did complete it, they were way less likely to release that kit to police and kind of start that judicial process. Also, when people were getting forensic photography or injury documentation being done, that decreased significantly as well. And so our conclusions for this is that there were definitely decreased admissions for sexual assault and intimate partner violence during wave 1 of the COVID-19 pandemic. And there were concerning trends that we noticed in care seeking and assault patterns. So we saw way less younger people, likely because they didn't have the agency or ability to get to us to get help. We looked at arrivals by ambulance, and while it was not statistically significant, there were an increased arrivals by ambulance, probably because people are not able to just come by themselves during that time frame. And people were reporting to police less likely, and were also not as likely to engage with forensic care, likely because they had to go back home or shelter in place with someone or find a shelter location, which was very difficult to come by during the pandemic time and is actually still quite difficult right now due to restrictions and gatherings. And, you know, Canada's in a way worse state than you guys are right now. We're hoping to catch up with our vaccines, but we're still running into issues with people having to go back to violent environments, and so therefore not wanting to go to that formal legal representation to get themselves in that pathway. And so this was a very informative study for us as we move through the further waves, because we have implemented a number of changes to try to outreach to people who are locked at home and to have innovative ways such as non-traceable text messaging and chat functions, as well as more video conferencing such that people don't necessarily have to leave their home to access our service. And I'm happy to address any questions for anyone.
Thank you so much, Dr. Samspel. That is sad and scary because, like you mentioned, I don't think that there were less sexual assaults or incidents of intimate partner violence. There were probably more. They just didn't come and get care.
Yes.
I know that there's some literature on the pediatric side, so children, that there actually was an increase rate-wise for child abuse, and perhaps that's just related to the parent who's not the abuser can bring them in and has a justification. But I feel for the folks who had to go back home and stay with somebody who was beating them or assaulting them.
And it's interesting because when we've put into place this anonymous, non-traceable text messaging service, and we did a big media campaign around this, the numbers of that skyrocketed. And so we're looking to try to match some of that to the people that we are seeing physically within our program, and to see how this intervention may have tried to help keep people safe. So stay tuned, still to come. We're firmly in wave 3 right now. So we're trying to, you know, have this be a sustainable part of our program for the future as well, just because for those marginalized people who can't get to see us, it's a very difficult situation for them to be in, and we would like to be able to provide them care still as well.
Awesome. Really, really amazing work that's has already reached out and helped, I'm sure, many people up in Canada. So there's a question in the chat. Where does your financing for the media outreach come from?
So the financing for the media outreach, we got a small grant through the Ministry of Justice and Community Services. And so that was paid for to help us develop the technology. We were innovative and partnered with a local college, and this was their thesis project, was to build us this program. And so that was cheaper than hiring fully fledged developers at this point. And then the big media campaign, we did that along with our community partners and our policing partners as well, just to try to get this out over social media, traditional online medias, that kind of thing as well.
Also, on that same note, as far as the development of the, you know, secure text messaging that nobody can then find on their phone and that sort of stuff, was that costly to implement?
Anybody can access it, basically. So it is, what we did was we have a phone that is for our programs, basically, and there's somebody who has it all the time. So we hand it off and hand it over. And as anybody can attest to who has to hand over the phone within the emerge, it usually gets lost like once a week. For some reason, this one has not been lost. And so we have been very, very lucky for under the circumstances for this. And then it is just literally a text phone number. So like you would text a friend to be like, hey, you know, did you watch that last episode of X show? They can text in, and they actually based the encryption on it based off of some of the programs that BlackBerry or Research in Motion, which is another Canadian company, had used to have very secure end-to-end encryption so that it wouldn't be hackable, basically.
Awesome. Dr. Harlan said very important work. Thank you. Any other questions for this great abstract that's going to already has had impact? Well, I'm going to give you 4 minutes of your life back because we were scheduled to end at 11:48 and we are ending at 11:44 Central Time, 12:44 for those of us on the East Coast. So thank you so much. I loved all 4 of these presentations, and I so look forward to us getting together in person, hopefully next year, when we are supposed to meet in New Orleans, and maybe Canada's border will be open so you can come and join us. Fingers crossed.
Hopefully. Thank you, everyone.